strategic health program at Connect Health was founded by our doctors here, Dr. Lawrence Cheng and Dr. Ashley Riskin, who saw the need for a more proactive, preventative, and system-based approach to health and healing. They have a unique and broad perspective on healthcare gained through their emergency medicine backgrounds and additional training in functional and integrative medicine. Both of them have completed a fellowship in integrative medicine, University of Arizona, and are certified functional medicine practitioners. They're currently exclusively practicing longevity medicine. Without further ado, Dr. Lawrence Cheng here.
Great, thank you, Hedy. And once again, thanks for being here, and Hollyburn, thanks for inviting us here. So I'm an emerge doc, 25 years in the trenches, St. Paul's Hospital. Let me tell you, lots of stories. Part of my journey has been seeing so much disease at the end stages, heart attacks, strokes, cancer diagnosis. How do I help people before they get to the emerge department? How do I get people upstream before they have a heart attack or stroke at 2 a.m. on the Friday night, right? So for me, the journey has been from downstream medicine, acute care medicine at the end stages, but how do we help people prevent disease and get as upstream as possible? So that was really the driving force of why we started this clinic here. Okay, so what's our objective? I think this is everyone's objective. Living longer, living healthier, sailing off into the sunset, right? I think we can agree that's all our objective here. So really our mission here is to help people live healthier, happier, and longer lives, to help detect disease before they manifest, to optimize wellness and implement longevity strategies. So I think some of you guys have seen this longevity curve here. So on this axis here is years healthy, right, in good functional status. And on this horizontal axis is years alive, right? So unfortunately, the curve starts to go down around age 40, right? So, but how quickly it goes down is determined by many, many factors, right? And so the whole point of longevity medicine is how do we push this curve out from the green one to the red one to keep your level of function as high as possible and then go straight down at some determined age into the future, right? So this slow decline is what we're trying to avoid, which is years of ill health, right? How do we eliminate those? And so what we do know now with current science is you can get from the green curve to the red curve probably a good 7 to 10 years of good, what we call health span, we'll define that, by good early detection strategies and optimal lifestyle, right? So 7 to 10 years is achievable for everyone. Now, beyond the 10 years, I think there are going to be some really big breakthroughs, probably in the next decade, that could take us beyond this additional 10 years of good health. But for sure, there's probably 7 to 10 years that is achievable now with the right strategies. Okay, so health span. So this is the difference. Lifespan is just years alive, right? So I think no one wants to live longer in poor health, right? So it's not about just extending life. It's about extending health span. So health span is defined as years alive in good health and good vitality. And there's different components, right? So the mind, right? If you don't have good mind, the rest doesn't matter, right? So that's memory, that's processing speed, that's executive function. It's the body, right? So good functioning body, muscle mass, bone mass, freedom from pain, functional movement, mobility. And of course, none of this matters if we don't have this sense of spirit, sense of purpose, happiness and distress tolerance, social support and connections, right? So when we talk about extending health span, it's all these dimensions, right? And not in isolation. Okay, these 4 pillars of prevention, these really focus on the 4 conditions that really account for probably 80% of all deaths. And what's interesting is if you look at the centenarians, so the people who live past 100 in good health, they still end up with the same things. They still die of the same causes. It just seems that they start getting problems 10 years to 20 years later than most of us, right? So yes, number one, cardiovascular disease, that's heart attacks and strokes. Number two is metabolic dysregulation. So this is really the whole thing around diabetes, prediabetes, and insulin resistance, which is a big driver for many of the chronic diseases. Number three, cancer prevention and screening. Cancer, unfortunately, is pretty much the number one cause of death now in Canada and most developed countries. So it used to be heart disease, but cancer is the winner now. Number four, brain health. So Alzheimer's and other neurocognitive conditions. And if you guys have probably know, the projections of the number of people with Alzheimer's in the next few decades is just simply terrifying. So everything we can do to prevent brain health issues is going to be huge. So these are the four pillars where we want to really focus our time on. Now, this is a slide called The Hallmarks of Aging. This is a recent paper. There was an original paper back in 2013 that's really trying to understand what is aging? What are the mechanisms of aging? So we'll go through this a little bit because it's worth understanding what are the mechanisms underneath aging. Oops, sorry, go back here. Okay, over here, there's something around genomic instability. So that pertains to our DNA, right? So our DNA is the blueprint for our body, but as we get older, it does look like our DNA copies seem to degrade, right? So there's this theory of aging called the information theory of aging, where, do you guys remember those audio CDs you used to buy to listen to music? Right? When you first get that copy, that brand new copy, it's clean, shiny, is perfect, doesn't skip. What happens after you play it 50 times? Start skipping, there's scratches. So it's interesting. So every cell has to copy and replicate every time. Every time it copies, it makes a few errors. And these copy errors get compounded over the years as we age. So that's where the genes sort of become unstable, the DNA gets unstable. So in terms of a longevity strategy, it's like, okay, how can we do everything we can to maintain DNA stability and DNA repair? Telomeres, these are the caps at the end of the chromosomes, and it does look like as we age, they get shorter and shorter and shorter. So are there ways that we can keep these caps in place and in fact potentially lengthen? And it does look like lifestyle changes can actually lengthen our telomeres, and that might translate to increased lifespan and health span. Epigenetic modification. So epigenetics is basically the environment. So all the environmental influences on how our DNA is translated. Our DNA is the blueprint. It has to be read like any blueprint, and the environment affects how our DNA is translated. So understanding all the environmental effects. This could be pollution, this could be stress, this could be nutrients or lack of nutrients. Loss of proteostasis, this refers to proteins. Proteins are the building blocks of our body. It forms all the machinery that drives all of our biochemistry. And as we get older, the way our proteins are regulated seems to go a bit awry. So how do we understand to keep this protein regulation as good as possible? This is called something called macroautophagy. This is kind of technical, but this stuff is important because this is where we're going to get these longevity strategies. Autophagy means cells that have to be replaced and recycled. So there's something around the recycling of cells that get old. And it does look like fasting actually helps improve our recycling of cells that no longer are functional. Deregulated nutrient sensing, again, this is also around something around our body's ability to regulate nutrients And again, fasting does look like it turns on survival programs, which seem to be beneficial for the whole organism. Mitochondria, these guys are the powerhouses of the cells. And it does look like if these guys can function better for longer, then our whole body systems will function better. Cellular senescence, these again are cells that get old and have to get recycled and taken out of the system. Stem cells, I'm sure people have heard about stem cells. Stem cells are cells that can form into any tissue. So when we're born, we have the most number of stem cells, but as we get older, the reservoirs start to get exhausted. But are there strategies that can keep our stem cells, the reservoirs, not getting depleted? So interestingly, people are banking their stem cells at as young an age as possible with the future hope that maybe we can actually re-inject, reboot the system with younger copies of ourselves. So very, very interesting. Altered intercellular communication. This is around hormones, right? So these molecules that communicate with organs in our cells, and so there's something around optimizing hormones and other messengers. Chronic inflammation seems like it plays a big part in the aging process. So can we identify where this inflammation, how do we reduce it? And dysbiosis refers to our microbiome. So the entire ecology in our gut that seems to play a very pivotal role in all of our health. We're still at the very bleeding edge of understanding the microbiome, but I think there's a big key there with aging. So yeah, so this is the latest in terms of understanding of what aging is. So fascinating, and tons of science is going into this.
All right. Live longer, live happier, live healthier. We like to set that as, imagine yourself as a 90-year-old living independently, being able to get your own groceries, go up the flight of stairs, put your luggage up top on the air flight, on the plane that you just been able to take, and really living well, being able to do a push-up. And so then we talk about how do we train for that 90-year-old self where you can do a push-up, maybe a pull-up, and we backtrack 30, 40 years, and that's the training, and that's where it begins. The nice thing is you can train and start at any point. So you'll hear some very incredible tales of people in their 80s that have never been to a gym, and they make their first, and of course everybody here has probably been to a gym given we're at a country club with a gym, but it's never too late, and that's the bottom line. So the strategy then, if we have set our goal, becomes the following. So if we want to prevent and delay the onset of chronic disease, like that's the number one way that's going to kill 80% of us, by picking these things up early, and we'll talk about that. Detecting disease as early as possible. And then down here, developing a lifestyle that will make you feel better. So to recap, prevent, detect early, and then feel better while you're actually alive, right? That's the whole point. You want to be living and feeling like you're 50 or 60 when you're 100, potentially. No one wants to feel like they're 140 when they're 140. So that's where we're heading. All right, so a little bit. I mean, what we're trying to do is test everything under the sun that we can, figure out what has the biggest impact, and then go from there. So we do look at brain health and gut health and cardiovascular health and toxic exposure, genetics and pharmacogenomics, which is the interplay between our genes and drugs and foods that we take, immune markers, hormone markers, and then a whole host of diagnostic images from whole body MRI, which we're going to talk about, bone density testing, DEXA. All these things are now available to us, and 20 years ago they were not. So there's a different landscape that we're practicing in. So this is just a brief table demonstrating a cohort of about 30 healthy people. So these are corporate executive type people, 45 to 65, in the insurance world. So not always healthy, given the alcohol intake that we observed during lunch hours. But this is what we found, and these are new, unknown, significant findings. So this is important. If you want to live a long, healthy life, be that 90-year-old that can do a push-up, you've got to figure out what your bone density is before you're 90, for example. And so what we found was over half of the people in this cohort, and this was predominantly men, so a population you wouldn't expect to have bone issues, half of them had bone thinning, which we can define. And we'll get to a few slides of that in a little bit. I'm not going to go fully down the list, but a few highlights. Insulin resistance, which is a precursor to diabetes, 4 out of 10. Fatty liver, so This fat collecting around your organs, over half of the people had a fatty liver, and these are healthy people. Low vitamin D, omega-3, over 60%. Non-ideal lipids, so high cholesterol, over 60%. Undiagnosed hypertension, and this is the number one, well, either smoking and hypertension are going to be your first and second risk factors for developing cardiovascular disease or disease of the arteries. And at least, and this is low probably, there's probably over 35 to 50% of the population walking around not knowing that they're a little bit hypertensive. So it's an important thing to start looking. This is the Alzheimer's gene, but it has more implications. There's a person here that had 2 copies of the gene that gave them a 10 to 12-fold increased risk, didn't know it. And 1/4, now this is a younger population per se, but up to 1/4 of them weren't up to par on their pap smears, their mammograms, their stool for occult blood. So just the standard basic evidence-based cancer screening guidelines, up to 1/4 of people. Over 30% of people had some sort of significant finding on their MRI. That wasn't undiagnosed cancer, but it was some of the things that I just mentioned above. We picked up 2 overt, I guess I am going through the whole list, I promise not to. We picked up 2 full-blown diabetics that didn't know that they had any issues. And we picked up 1 celiac disease, which is an issue with gluten. And so this is a small cohort, and so you try to figure, like, you take a step back, you zoom out, how can we have big impact on society and health? Yes, it costs some money to do these tests. If you pick these things up 20 years before they cause a problem in the emergency department, then you're probably winning the game. All right, switching gears, a little bit of a primer of the artery. So this is an artery that we're born with. As you can see, there's nothing in it. It's soft and pliable. It's not rigid. And over here, this is the end that we see in the hospital. This is a heart attack. So that's a clot. And everywhere in between, this process is multi-decade. And so the problem is you're asymptomatic until about here. Root causes, I mentioned smoking and uncontrolled hypertension, but when you look at the physiology of what causes this whole process, it's elevated lipids. So you hear about LDL, the so-called bad cholesterol. It is necessary to be there, but it's insufficient on its own to cause heart disease. So that's indisputable. You're going to get some debate about the treatment and all of that, but it is a player. It's not necessarily the cause, but it needs to be there. And so the more you have, the higher the risk in general. Inflammation, oxidation, and then endothelial dysfunction, which means an injury to the lining of the vessel. So you need all 3 of those things. You need cholesterol or LDL cholesterol. You need endothelial dysfunction, some sort of inflammation. What happens is you injure the artery wall. Your immune system goes in there and tries to repair it. LDL cholesterol, because it's smaller, it's going in and out of the wall. It gets stuck, and then you have this whole foam cell, this immune response, turns into a plaque. It's your body's healing response to a chronic insult, which is a trend in chronic disease. And we can measure these things now. So we're measuring oxidative stress markers, inflammatory markers over here, and down here you'll see, it's hard to see on the screen from where I am, but you do have, these white things are calcifications, and here's your plaque, and here's your rupture. Okay, so back to Tom. Not quite to Tom. We wanted to highlight the difference between the different ways of measuring LDL cholesterol. And the analogy that we like to talk about is a highway. So you can have a highway with a whole bunch of big trucks, and that's it, and they're going the same speed and everything's fine. Then you introduce a whole bunch of motorcycles speeding in and out. Which scenario do you think is going to cause a problem and cause that accident or cause that endothelial dysfunction? So turns out when we measure LDL at our normal lab, and this is a Canadian unit over here, 3.25 is high normal LDL. That's a concentration. But you can actually have a lot of big, happy, fluffy trucks or a lot of angry, mischievous motorcycles running around. And you don't quite get that number when you look at LDL alone. And so both Maria and Jerry are sporting the same lab test from a concentration point of view. So there are a few other markers that can help differentiate Maria's from Jerry's. Tom is a Maria. And so he has this lipid profile when he first came. So red is not good. And this is American units, but essentially this is what you'd get at your Life Labs panel. So he had high LDL, he had low HDL, he had moderate triglycerides, which are lipids that are associated with glucose and carbohydrate intake. But to highlight this number here, this LDLP, he has a lot of LDL. So it's counting the actual number of LDL particles. So they're small and numerous for him. So that increases his risk. Way down here, there's something called lipoprotein A. All these big, long words turns out quite important. And this one here, you can think of that as an angry, angry, angry LDL. And it's genetically determined. And that's what gives these family histories, in part, when you hear of a 39-year-old guy dropping dead of a heart attack, there's a decent chance that LDL or LP little a is one of the factors. So we're now screening for that because it changes our whole philosophy and lipid management. Down here, ApoB. This is the one that we can do at Life Labs, and this does, it brings everything together, and a lot of the targets that we have are for this marker down here, and that encapsulates almost all of what you see above in one number. Bottom line is his is really high. This is a CT angiogram, or this is a CT scanner. This is the heart. Just briefly for him, he had in 3 vessels calcified plaque, and he also had some non-calcified plaque as well. No real obstruction. So what that means is he had high plaque burden, but the blood flow to the heart was fine and unimpeded. So you look at this guy, he's at 49 at the time of, or 47 at the time of this test, and he's got a lot of plaque in all of his arteries, and he's got terrible looking family history and terrible looking lipids. And so he did well to come and look, but if you're in the normal track, there's no real guideline on when to start testing for these things, and so a lot of this gets missed. And the first presentation too many times of a heart issue or these issues is a heart attack in the emergency department. So we're trying to avoid that as much as possible. In his case, he ended up needing 3 different medications, and one of the newer ones that's injectable. And over here is the green. Now, there's nothing magical about this. We don't have a great lifestyle intervention that can reproduce this sort of improvement. But he's on a statin, another medication called ezetimibe, and another medication called Repatha, which is one of the newer ones. The point that we wanted to make was he's in his 40s, he was fairly proactive, identified a pretty significant risk that likely would have ended his life in the next decade or 2 untreated. And now getting this little number down here, sub 60, and this number here, LDL, in Canadian units, sub 1, which, I don't know where I went. There we go. Actually puts them into this plaque regression area. So now they're noticing with these new therapies that we can reverse plaque, which wasn't thought to have been possible not that long ago. And so he'll go for his repeat CT scan in a few years, and at the very least, we hope for no progression for a young guy. Because the truth is, if we want to crest into our 100s one day and live a healthy life, we've got to solve the problem of the rate-limiting step, which is our arterial health, so stroke and heart attack. Those are you can escape cancer, you don't get Alzheimer's, your vessels end up getting you a lot of the time, and that's part of the strategy. Okay, these are the things that we're testing for now that are readily available in Canada. So we're testing for lipids, inflammatory markers, which includes uric acid, which is a gout marker, but also if you have high uric acid, you have an increased risk of getting hypertension. So if you've got gout, there's a correlation between that and hypertension and endothelial injury. CRP, which is an inflammatory marker, homocysteine, which is an inflammatory marker. We're looking at some genetics, blood pressure, of course, some imaging, ultrasound, stress testing, metabolic health. So if you have diabetes, of course, that's a major factor here, and some nutrients. So we're trying to look broadly. Our clicker, okay, metabolic health. Staying over there.
Okay, great. Thank you, Ashley. Yeah, so, for us, that's a huge save, the case of Tom, right? So again, we've gone upstream. He didn't have any symptoms. We identified a significant problem, and we're correcting it, right? So it's very likely that he would have had a heart attack probably in the next 10 to 15 years. And I think with early detection and treatment, he'll never have a heart attack. So that's a huge win for him. It's a huge win for the system, right? Okay, so metabolic health. Metabolism really is how do we convert food, energy substrates into energy, and how do we store it, right? So this is really key. Like I said, how we deal with this metabolism is the root cause of many, many issues. So here's a very interesting slide. So we call this cardiometabolic syndrome, or can be related to insulin resistance or diabetes is kind of the big term here. Look at all the conditions that are basically related to this issue with metabolism. So of course, type 2 diabetes, cardiovascular disease, this is increased lipid issues, high blood pressure, erectile issues, polycystic ovarian syndrome in women, Alzheimer's, osteoporosis, this is non-alcoholic fatty liver disease, obesity, sleep apnea, sarcopenia is like losing muscle mass, which we'll talk a bit more about. They are all related to this root issue of problems with your metabolism, right? And we're talking mostly how your body deals with sugar, glucose levels, right? So it's the root cause of all these problems. Now, the most interesting thing, important thing, so how do we diagnose diabetes, right? So typically people start having symptoms, very thirsty, they're peeing too much, fatigue. We do a blood test, a fasting glucose, and it's high, right? But the thing here to notice, so 0 is time of diagnosis, okay, this -5, kind of 5 years before diagnosis. You can see that the fasting glucose level is climbing for at least 5 years before we get the diagnosis. And people often have no symptoms. Your insulin levels, right? So insulin's the hormone that helps bring the blood sugar into the cell to burn, to be used as fuel or stored as fat. Your insulin levels start going up. Look at this, almost 10 years before the diagnosis and 5 years. So what we need to do is we need to try to detect diabetes as early as possible, even before you have obvious symptoms. So if you start looking at insulin numbers way before, they start going up before your sugar levels goes up, right? So that's the big point is diabetes, your high blood sugar is the end stage of a problem of insulin resistance that's been going on for at least 5 to 10 years, right? So we're trying to detect insulin resistance before your blood sugars come up. Okay, so that's really, really key. What's wrong with the slides here? Okay, so there's some really great devices now that diabetics are using, and anyone can buy this now, is you can track your blood sugar in real time. So you guys have probably heard you can put a patch on your arm, and basically with your phone, you can actually get your blood sugar reading minute to minute, right? So we're recommending this to a lot of our clients now because that's the only way to really understand how your body deals with sugar and carbohydrates. And it turns out that's really, really important, right? So I think part of the whole longevity strategy is understanding how is your body dealing with sugar, and if there's some issues, you got to start dealing with it. So low carb diet, potentially intermittent fasting, potentially supplements or medications, because you want to avoid getting into diabetes. Okay, so here's an interesting example of what you can learn with starting to use these continuous glucose monitors. Okay, so here's a meal. This is a curve of sugar, glucose, and after you eat a meal, you get a spike of sugar, okay, glucose, and then your pancreas squirts out insulin to try and bring down the sugars. If you eat pasta first, which we know is carbohydrate, turns to sugar pretty quickly, and you eat broccoli second, you can see there's a big spike in your sugar and then it comes down. But if you eat your broccoli first, which has a lot of fiber, and your pasta second, you have a much less of a spike. And ultimately, you don't want these spikes, right? So these spikes over time, high spikes of sugar, high spikes of insulin, is what's going to increase your risk for type 2 diabetes. But if you're eating much more fiber in the diet or a low carb diet, you're going to have less of a spike, right? So this is the things you can learn with these continuous glucose monitors. Just to show you, we're trying to measure, again, not just your fasting glucose, which is the last part that goes up in this whole insulin resistance story. So we're trying to measure insulin resistance. We're measuring, these are some of the markers here. Hemoglobin A1C, most people probably know. That's kind of like your average sugar level. Fasting glucose, we're measuring fasting insulin. We often do this glucose tolerance test where you actually drink 75 grams of glucose and we stress test your insulin sensitivity. We're tracking how much adipose tissue is in your body. We're looking at your muscle mass. We're looking for fatty liver, looking for uric acid. So multiple biomarkers to try to identify issues with insulin resistance. The main point here is elevation of glucose and symptoms is a late sign, right? So again, we're picking up stuff too late.
Okay, so switching gears into measuring the physical body and paying a lot more attention lately to this than we had previously. So body composition, muscle mass, bone density. Oh dear. Okay, so starting with bone density. So it's not a very attractive or sexy topic when you're 40 to know your bone density. And it's not terribly important when you're 40. And it becomes important in your 50s, 60s, 70s, and 80s. So look at the yellow. This is the cause of death, accidental deaths. And yellow is the falls. So your mortality, if you fall in your 80s and you break a hip, is about 50% in that subsequent year. And it's not that high in your 70s, but it's not insignificant. And so if you want to be that 9-year-old doing the push-up, you want to fall and get back up. And so looking at your bone density earlier and trying to do everything you can to keep it strong is the strategy. Essentially, the way we measure bone density, this is an X-ray technology called DEXA, and we compare bone density to a 30-year-old optimal adult bone density. So that's the comparison. So you ever look at your score, you're going to get a minus something, and that's basically telling you how far away you are from the typical 30-year-old, 40-year-old bone density. And the definition of osteoporosis would be 25% mineral or bone density loss compared to that 40-year-old self. Osteopenia would be about 10%, give or take. And so you can look at all these scores. The bottom line is, like all things, the colors didn't show up in here, but this middle line would be, the median. And most people in their 70s or 80s, I guess you can't see that, but down here there's a red zone. So osteoporosis is around here, somewhere about there. The point is, if you follow the average trajectory, you're most likely going to have osteoporosis in your 80s. And if you're below average, that's going to just come earlier. And it just starts to go down as we get into these last 40 years of our lives. So we want to build our bone density no earlier, the better, and try to keep this line as flat as possible. And we measure your hip and we measure your L spine, your lumbar spine, because that's where we get these compression fractures or these osteoporosis-related fractures. So this particular person's in her 60s. She's way down here. So she's 3 standard deviations away from a 30-year-old. So she's not doing too well on that regard. And ideally, you catch it a lot earlier in life. Come on, clicker. Maybe do you want to just stay over there? Okay, perfect. Okay, so switching gears, we mentioned the visceral fat piece. Dr. Cheng mentioned it around metabolic health. Just wanted to highlight that on the same DEXA scan, we can get a sense of what your visceral adipose tissue is. It's down here. So on this individual, he has 978 grams of fat that are around organs. This is the fatty marbled organ syndrome. And our goal for men would be less than 500, for women less than 400. And that just points to metabolic health. Yes. Okay, switching gears to sarcopenia. So this is muscle loss. This is actually one of the biggest gravities of the aging process. And it's tricky. So you look at these two arms, they don't look terribly different necessarily, but you can tell when you see the red part, the muscle, that you've lost some here. When you do a CT scan, this is a thigh. So externally, the appearance is not too different. You have the same size of a thigh, but you get more of this marbling, and you get all this white is now fat. You can keep your same body weight your entire life and be losing muscle along the way and gaining fat along the way. And not, I mean, you can tell by looking in the mirror and by lifting things, but we try to quantify it, knowing that after age 50, give or take, you're going to lose 1 to 2% compounding of your muscle mass every year. You're going to lose 1 to 4% of your strength every year. Strength is actually even more important than muscle mass if you had to pick one. So again, you got to be doing your push-ups every day and never stop, and then never get injured on our longevity journey. Okay, cancer screening. So cancer's scary, right? We don't like the word cancer, and it's 1 in 2 of us will, in our lifetime, either be touched, or 1 in 3. It's 2 out of 5 are expected to develop cancer in their lifetime. And 1 of 4 is expected to die. And so this is where we diverge a little bit from some of the guidelines out there. It's kind of scary to have to follow the guidelines and wait for a symptom to develop to then present and have your diagnosis given to you at stage 3 and stage 4. So this is where we're looking a little bit deeper, looking harder, and we're going to take a bit of noise and a little bit of turbulence along the way. And this is where the whole overdiagnosis versus too early versus too late comes into play. But our strategy is to look deep and look hard and layer lots of different technologies on top of each other and try and give an evidenced and informed opinion. So we're doing whole body MRI. We're using Pronovo on Broadway. If you're going to pick one, that's the spot to go right now. We're going to do skin checks. We're going to do colon cancer screen earlier. Our preferred would be to start at age 40, looking for blood at the very least, and if there's an opportunity, getting a colonoscopy. You're going to keep going to your dentist. You're going to floss, but aside from that, you're going to get your dentist to look for oral pharyngeal cancers under the tongue. Prostate, we rely on that MRI, and we do look at PSA as well. Mammogram, ultrasound, plus or minus, or with the MRI, is our breast cancer strategy. And then the next thing that's coming, and in the States it's here, and some companies can get it in Canada, and this is this looking for circulating tumor DNA. So a blood test looking for cancer cells in your circulation. And then another piece that's coming is a metabolic signature. So now we can measure hundreds and hundreds of proteins and metabolites. And it turns out if you can capture a signature, so if you have 30 proteins and metabolites in a certain way, that you're likely to have a certain condition. And they're finding those to do with cancer. All of these will miss things. All of these will find noise and overcall things. When you layer them all together, the feeling is that you're going to improve your statistics and sensitivity and specificity. All right, so again, best prognosis is stage 0 or stage 1. So you're trying to pick these things up before they turn into metastatic disease. One example would be, say, colon cancer. If you notice, if you have stage 1 colon cancer versus stage 4, it's the same chemotherapy that you're given. The survival rates are way different at 5 years. So why is that? So it turns out tumor burden and number of tumor cells matter. So earlier is better. That's an MRI. All right, brain health. Coming over here.
Great.
I'll keep it because it's
Okay, thanks, Ashley. So again, this is also kind of a scary thing. So certainly as a Merge Doc, we've all noticed that we are diagnosing first diagnosis of cancer more and more in the Emerge department. And again, it's just because there's more cancers around, and unfortunately, so many people present late. Pancreatic cancer, we don't have any screening for it, and people don't have symptoms until they're stage 3 or 4. So I don't know how many people, unfortunately, they come in, they've had abdominal pain for several weeks, and we do a scan, and there's a mass in the pancreas. So again, I think our approach is really quite aggressive screening for cancer, incorporating whole body MRI as the best approach there. Okay, so brain. So of course, the brain's important, and we want to make sure we can do everything to screen for brain health issues. So again, we try to do a very broad approach here. We are doing brain MRIs, and again, we're finding changes in people's brain MRIs before they have any symptoms, right? So if we start seeing some white matter changes, then it alerts us to say, okay, there's something going on here, even though you don't have any symptoms. The brain is part of the whole body, so metabolism counts a lot. Lipids, cholesterol levels also really affect brain health. Nutrients, so things like B12, vitamin D and omega-3. These things are, again, key determinants of brain health. So we don't routinely look for these things. So we want to measure these things and optimize them. We're looking at some genetics, especially something called ApoE, which people might have heard about. And it does look like if you can identify people with ApoE4, then you have to be much more aggressive in preventative strategies. Because those people, as Ashley was mentioning, they can have like a 8 to 12 time fold increased risk of Alzheimer's. So again, this is one with these quite essential genetic tests that we do on everyone. It's fairly easy to do, but if you can identify it, you can really do something in advance for that. We're doing some baseline neurocognitive testing, just to, like, how's your brain function, reaction speeds, cognitive evaluation we use this EEG cap, measuring electrical brain waves, again, just to pick up stuff early before any major symptoms. Sleep is a huge determinant of brain health. So we're really in favor of things like sleep trackers, trying to optimize kind of deep sleep. And we're also looking at things like heart rate variability, which seems to have pretty good concordance with our stress levels, how we deal with stress, right? So these are all big drivers of brain health. And lastly here is we really try to measure people's stress hormone levels, so cortisol, right? So cortisol in the long term will start causing problems with many things, including metabolism, but also brain health, right? So again, we have quite a comprehensive approach to brain health screening.
Skip.
Yeah, this slide didn't go, we'll skip that one. Okay, so we're gonna pivot now from sort of early detection and screening and testing to tactics and some practical tips for you guys. So we're gonna really look at the tactics around things like nutritional biochemistry, right? So how can we tweak and optimize that? Exercise physiology, sleep, stress physiology. These are all foundational. So we're trying to find things that are, where we can optimize these key physiology points. And then on top of that, then we consider things like, potentially supplementation with natural supplements, medications, hormones, and regenerative therapies is really more for the future, but there's some very interesting things around stem cells where, again, we might be able to reboot tissues and rejuvenate them. So.
Okay, time differences, there's a whole host of issues. And so we try not to get too hung up on the what you eat, so the dietary restriction, so the DR. So our philosophy is, we are borrowing from some of the leaders in the space, so we have four main levers that we will pull. And so what we tell people to eat around dietary restriction, within a certain number of obvious things, and we'll talk about that in a moment, we try to give broad advice and then narrow in for specific situations. We spend a lot of time talking about time restriction. So that's the whole intermittent fasting, prolonged fasting, mimicking, fat adapted fasting, protein fasting, all these different things and strategies we'll use at different scenarios. And our philosophy has shifted over the last several years. It used to be that we thought fasting was a terrible idea. Slow down your metabolism. How could you do that? You're going to waste away. It turns out we are born and evolved to fast. And so during times of starvation or lack of supply, we'll have extra energy and adrenaline to go hunt and look for food. And we're not going to waste away. It's a survival mechanism. Unfortunately, in our current culture, we have ample food at all times, and we're not really designed for that. If you are someone who has diabetes or obesity or struggle with weight, then you would have survived the famine, but it turns out it's not the optimal genetic pool to have for today. Caloric restriction, it works. It's not really easy to do, but you'll see papers talking about a 30% reduction of your calories over a long period of time will prolong life. So our goal is to always be pulling one of these three. So eating less, eating the right stuff, or eating at different times. Often we'll talk about two things, maybe all three. Most people do none of these three and eat whatever they want, whenever they want, and as much as they want. And that's the North American or the standard American diet that you'll hear about, the SAD diet. A few basic concepts, though, that we do talk about with all of our patients, and we talked about insulin and glucose, but we really want to avoid those insulin spikes. And sometimes you won't know what foods for you will cause that spike, so those glucometers that you can wear are quite helpful. But we do aim for low glycemic meals on that regard, and overall lower processed foods will get you there a lot easier. So if the bag lists ingredients, you probably put it back and you just shop around the outside. That actually is true. If you don't recognize an ingredient on the bag, you put it back. Or if you do have it, try to limit your number of Doritos that you will eat. Protein, high quality, but you do need more, it turns out, than we thought. And there's a bit of a debate around this. Given its relationship to muscle mass, we are actually advising, especially as we get older, to have more and more protein and really going with quality, not so much the cheapest and most available. So we do talk about animals being grass-fed and finished, if at all possible, if it's that type of meat. If you're going for fish, then you want to be careful of toxins. It's a challenging world to live in around the food supply, but general principles are these. And we are aiming for 1 to 1.5 milligrams per kilo, for grams per kilo, that's a typo. Or it's a gram per pound. So if you're 150 pounds, that's a lot of protein. Most people are probably at 20. So we're trying to at least go up a little bit to try and get that muscle mass loss to go down. I talked about fasting a little bit, but this is your fastest way to undo an insulin-resistant scenario. If you fast for long enough, your insulin will go down. When your insulin goes down, you have access to your fat stores. And so we will use that as well as a strategy for helping with high visceral fat or body fat. So those are a few concepts around nutrition. If you are interested in fasting, this is a decent paper. Sorry again for the color. This is an intermittent fasting protocol where they're eating in a small window between 8 and 2. So you'll hear about 16-8. So you're fasting for 16 hours, eating for 8, and there's different variations. But generally, you're going to see a drop in after-meal insulin, a drop in blood pressure, a drop in oxidative markers, an increase in insulin sensitivity, which is what you want, an increase in how well your pancreas works. You do see a transient rise in your triglycerides from time to time. In our experience, we haven't seen that, though. On that earlier chart, the hallmarks of aging, autophagy, body-eating self, one of the most powerful strategies to do that would be fasting. And so some people really take it seriously and will do a 3 to 7 day fast on a periodic basis. This guy here, Jason Fung, he's a Canadian nephrologist. He wrote a bunch of books. This was our first foray into the world of fasting. So if you're interested, this would be a top book to pick up. Okay, switching gears to fitness and strength. So how you move will define your life, and that is never more true than as we age. So I have a family member that is scared to go down onto the floor and play with her pets or grandchildren. She's worried about being able to get up, and she's only in her 70s, and that's been the case for a long time. Hand strength, all of that, and that is a scary place to be. If you're worried about being on the floor and never being able to get up, and if you just are lowering yourself down, that's not what we want. And so again, we got to train for the Olympic Games when we're in our 80s and 90s. This is a paper looking at mortality and cardiorespiratory fitness. Essentially what we wanted to highlight is this is the lowest fitness. This is below average fitness. The jump from here to here is actually quite significant, and I'll show you in a moment here. It lives over here. So low versus below average has a 2 times survival benefit over a decade. So you can still be below average, but if you're not low and you're just a little bit below average, you'll have a 2-fold increase in survival at a 10-year mark. Just to give you a sense of the magnitude that we're talking about, if you are in elite fitness, which actually is not that hard because you're in the top 5% of the population, and the population tends to be not that fit. But if you go from low to elite, it's a 5x difference in mortality over a decade. End-stage renal disease is a 3x. So it's more powerful than end-stage renal disease, and it's way more powerful than stopping smoking, risk of heart disease, diabetes, hypertension. So there is no one intervention that will improve your longevity more than exercise. So cancer reduction, cardiovascular disease reduction, Alzheimer's prevention. And it's the one that we struggle a lot to get our patients to do. Now, we're at a club where presumably most people here are doing some sort of fitness, which is amazing. And so we're probably preaching to the choir, but you'd be surprised the number of people that really struggle to get in the basics. And the basics are not just whether you put in your 30 minutes per day at the gym, it's what you're doing the other 17 hours that you're awake, or whatever the number is. Are you sitting at a desk? Are you trying to click the button that won't click? Trying to clear the, or what does that look like? And so you want to move, you want to walk, you want to get up, you don't want to be sitting, you don't want to be just standing still all day, you want to be doing lots of different things. We're not going to spend too much more time on this, apart from these are the 4 core areas from exercise that we'll look at: stability, strength, aerobic efficiency, and anaerobic peak. So you probably are versed in this. One area to think about that we're spending more time with our patients on is this whole zone 2. So this is the maximum output that you can do while using oxygen. And so essentially it's, are people familiar with lactic acid? When you're working really hard, you get that burn. Part of that is due to hydrogen ions, but we talk about lactate in that scenario. And so we're talking about trying to get that zone where you're just below accumulating lactic acid as efficient as possible. If you take a Tour de France cyclist, they can go forever, and they do, like hours and hours at a really peak performance, and that's their zone 2. That's my zone 5. I'm sprinting to keep up to their zone 2, but they've got their muscles huge and their mitochondria efficient, and they've trained that zone. It turns out that the more you train that zone, the more it helps your cardiorespiratory fitness. So you don't need to sprint all the time. You can train in that zone and get a lot of benefit. But we want you to sprint, we want you to train that zone, we want you to do a lot of strength training for your muscle mass, and we want you to be stable and not be tipping over and falling. Yep. Click it on the way over. All right.
2. So neurologic disorders. So there's actually a lot of evidence connecting chronic poor sleep with increased risk for neurological conditions, including Alzheimer's. Inflammation. So again, chronic poor sleep can cause chronic inflammation just by itself. And chronic inflammation is a big driver for all these chronic diseases. Cancer, breast and prostate. Unfortunately, again, with shift work in the emergency department, nurses have a 1.5 times the increased risk for breast cancer because of shift work. So the WHO has actually labeled shift work as a possible human carcinogen, because it just messes up so much with our circadian rhythm. So there's a huge connection with sleep and cancers. Heart disease, again, there's a big connection between poor sleep and heart health. Peptic ulcers, kidney issues, obesity, again, just related to poor sleep. And again, here, the diabetes, liver, insulin resistance, again, all related to poor sleep. So the biggest thing from certainly a longevity perspective is good quality sleep is just non-negotiable. You should prioritize that almost over anything, right? So yeah, I think everyone knows, like, minimum 7 hours, consistent sleeping, going to sleep. Earlier the better. The best quality sleep and deep sleep is actually earlier in the evening. So they say that every hour sort of before 11 p.m. is actually generally a better quality of sleep. And many of us are wearing these, I'm wearing this Oura Ring, which is a sleep tracker, and you can get really good information in terms of your deep sleep, right? So the technology here is really interesting here. So again, I think the sleep thing is, you have issues with sleep, then prioritize that as something to really optimize as best as possible. Raises blood sugar, causes sugar and fat cravings, increases our visceral adipose tissue, weakens our immune system, chronic inflammation, increases cardiovascular and stroke risk, causes digestive issues, even leaky gut, increase in mood disorders, anxiety, depression, insomnia, and suppresses our whole, what we call neuroendocrine axis, so all our hormones. So the stress piece is a huge piece around longevity and health in general. So the more we can regulate our nervous system and make sure we're not getting these huge, stress responses in our body, at least chronically, we're going to mitigate a lot of this risk. I'm a huge proponent of yoga and meditation. It doesn't have to be yoga and meditation, but things in this category, these mind-body practices, it's very interesting. The research around this stuff is getting very compelling. And they're using gene translation studies, they're using functional MRI, like really quite compelling evidence that is improving something called heart rate variability, which relates to our stress response, increases pain tolerance, reduces oxidative stress, improves insulin sensitivity, decreases inflammation. Right, so all these things from just doing practices on a regular basis to regulate our nervous system, really key. And again, relationships matter. And so very interesting, this study called the Harvard Adult Development Study, they followed people for something like 40 or 50 years. They tried to track all kinds of factors, and they tried to correct for blood pressure, heart rate, diet, all these things. And they found that the biggest driver of longevity and happiness was relationships. Wasn't genetics, it was relationships. Okay, just want to mention here, this is a topic in itself, what we call exogenous molecules. So these are molecules that we take from outside the body. There's a lot of interesting early work on these things. Some people might have heard of NAD and resveratrol. Again, these things may be helpful in prolonging lifespan. Hormones, I think there's a big piece in hormone replacement therapy. Medications such as metformin and rapamycin. Again, some very interesting early data that these things might increase lifespan. Things called senolytics. These are medications that can help clear out these cells that need to be recycled. Nootropics, these things around supporting brain function. Regenerative therapy, stem cells, and peptides. Again, this is still a little bit into the future, but very, very promising. We were at a conference not long ago on sort of exponential medicine, and they kind of jokingly said, okay, the next 10 years, just don't do anything stupid, right? Do everything you can to keep your body as best as you can, because there could be some breakthroughs coming. So, okay, again, just, future things, but age reversal interventions. There's a lot of things here that I think tremendous amount of money and effort and brain power is going in to look at how we might be able to slow down aging. Okay, just to wrap up here, and then we do some questions. Thank you for your patience. Keys to longevity. So really, the basics are an anti-inflammatory diet. The best study still is this Mediterranean-style diet. Number 2, make sure you understand how your body's dealing with sugars, your insulin sensitivity. Number 3, do some form of fasting, something. Number 4, move like your life depends on it, because it does. Prioritize sleep, learn how to regulate your nervous system, connect with your inner purpose, connect with others as deeply as possible. Expand yourself beyond your own self. We're big fans for data. You can't optimize what you can't measure. So diagnostics, testing, and tracking, I think, is big. And I think the future is in these exogenous molecules. Just going to end with this one quote from the founder of Strategic Coach, which is an entrepreneurs forum, Dan Sullivan. The mindset counts, right? So always imagine your future to be bigger than your past, right? So it doesn't matter what age we're at. There's something further, there's something bigger, there's an expansion, it's not a contraction, right? So I think it starts from that. If we can think of living bigger, big in whatever sense that is for you, I think that's the key. With that, I'll end here.